Hello, everyone. Thank you for joining the National Scleroderma Foundation and our speaker, Dr. Soumya Chatterjee, for this webinar on pulmonary arterial hypertension and scleroderma. Thank you to our event sponsor, Janssen Pharmaceuticals. My name is Karen Anitrello, Manager of Advocacy and Support at the National Scleroderma Foundation, and one of the many organizers for today's events. Before we get started, I wanted to share some quick notes on today's event. Today's webinar is being recorded and will be made available on the Foundation's YouTube page after this broadcast. The Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. We encourage attendees to use the question chat feature on the sidebar. Team members from our national staff will be hosting a Q&A segment at the end of the presentation. So let's get started. I'm happy to introduce today's speaker, Dr. Soumya Chatterjee. Dr. Chatterjee is a staff physician in the Orthopedic and Rheumatologic Institute at the Cleveland Clinic. He is also a professor at the Cleveland Clinic Lerner College. He is board certified in rheumatology and is a fellow of the American College of Physicians, the American College of Rheumatology, and the Royal College of Physicians of the United Kingdom. Dr. Chatterjee joined the medical staff in the Department of Rheumatology at the Cleveland Clinic in 2004. He is a general rheumatologist who sees patients with complex multi-system rheumatologic conditions. His special interest is in systemic sclerosis. In 2005, the Cleveland Clinic Scleroderma program was established under his leadership, and he has been involved in several research projects in scleroderma. Dr. Chatterjee enjoys and spends a considerable amount of time teaching and mentoring internal medicine residents and rheumatology fellows. He was awarded with Teacher of the Year by the Cleveland Clinic Rheumatology Fellows in 2006, 2010, and 2017. Welcome and thank you for joining us today, Dr. Chatterjee.
Good afternoon. Can everybody hear me and see me?
Yeah. Yes, you're good.
Okay, thank you so much. So thanks for joining. And this is an area that, obviously has a lot of updates in the last few years. And I thought it would be a good time to discuss pulmonary hypertension and systemic sclerosis. And this is meant to be an educational update for the patients, but I can understand there might be some physicians are interested in taking care of patients with systemic sclerosis. So the educational objectives of today's talk would be to learn essential information about pulmonary hypertension and systemic sclerosis. What exactly is pulmonary arterial hypertension? We're going to talk about how to identify the signs and symptoms of pulmonary arterial hypertension, how it is diagnosed, how it is treated, and what is the prognosis or outcome of this condition. So first of all, just a few words about systemic sclerosis. Systemic sclerosis or scleroderma is an autoimmune rheumatic disease of unclear cause, and it is characterized by progressive skin thickening or tightening, narrowing of the small blood vessels. So it's a disease of small blood vessels, variable degrees of internal organ involvement that determine the prognosis in this condition, and also immunologic abnormalities, which is characterized by the presence of certain autoantibodies. So before I go into the topic of pulmonary hypertension, I thought it would be important to learn a little bit about the autoantibodies in systemic sclerosis. So out of 100 patients with systemic sclerosis, about 90 to 95% should have a positive anti-nuclear antibody or ANA. And this is how you can tell the difference between primary and secondary Raynaud phenomenon, because patients with Raynaud phenomenon as secondary to systemic sclerosis will almost always have a positive ANA or anti-nuclear antibody. So out of these, about 25% will have anti-centromere antibody, which is associated with limited systemic sclerosis, formerly known as CREST syndrome, which is an acronym that stands for calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. I will explain some of these terms later. So this is the one subset of systemic sclerosis where there's a association with pulmonary arterial hypertension, and we will discuss that later. Less commonly, you can see pulmonary hypertension in the other subsets, anti-topoisomerase 1 or SCL70 antibody-associated diffuse scleroderma, anti-RNA polymerase 3 antibody-associated diffuse scleroderma are more related to interstitial lung disease and scleroderma renal crisis, respectively. Less commonly, these other autoantibodies are also encountered, anti-THTO antibody, anti-fibrillary antibody, and anti-PMSCL antibody. Of those, the first two, THTO and fibrillary, have also been associated with pulmonary hypertension. Antibodies are usually mutually exclusive, so if one antibody is detected, we shouldn't be looking for others. They tend not to be overlapping. And there is a subset of patients with scleroderma who clinically have all the features of the disease who do not have any scleroderma-specific autoantibody. And that's a minority, but it does happen. So as I said earlier, the one that we are going to focus on today is anti-centromere antibody-associated limited scleroderma or CREST syndrome, which is associated with pulmonary hypertension. Causes of shortness of breath in systemic sclerosis. So patients presenting with shortness of breath with a history of scleroderma, you have to consider important manifestations of the disease. Interstitial lung disease and pulmonary arterial hypertension are the two main causes of shortness of breath. However, there's a whole host of other causes. This is not a complete list, but some other causes of shortness of breath are left-sided heart disease, which can be seen in patients with scleroderma because of diastolic or less commonly systolic dysfunction of the heart muscle. So these patients are also at a high risk of aspiration because of esophageal dysmotility, and that leads to aspiration pneumonia and acute shortness of breath. Chest wall tightness is seen in patients with diffuse scleroderma who have extensive skin tightness that affects the chest wall, and that does not allow the lungs to expand because of the tightness and can present with shortness of breath. Patients with anemia, which could be a result of blood loss from the gastrointestinal tract, which is not uncommon in scleroderma patients, or even physical deconditioning. These are some of the other less commonly encountered but important causes of shortness of breath. So what's the most physical activity that you can do and what symptom limits your capabilities? That's important. A point that should be brought up during a visit with the primary care provider, also with the rheumatologist who's taking care of you. The scleroderma lung disease, that's the topic. So there was a time that renal crisis, which are the blue bars here, was the main cause of a bad outcome and mortality of systemic sclerosis. This was before the advent of the ACE inhibitors, which have now become the standard of care for people with scleroderma renal crisis and has significantly brought down the cause of death from scleroderma. What has gone up at the same time is lung disease, and this is a combination of interstitial lung disease and pulmonary hypertension. As you can see, the yellow bars over the decades have gone up, and seems to be the main cause of a bad outcome, morbidity and mortality in patients with systemic sclerosis. So just a little bit of the microanatomy of the lung. I think it's important to understand pulmonary hypertension. It would be good to understand the micro units that make up the lungs. So these are the air sacs or the alveoli, and tubes that carry air into these air sacs are the bronchioles and the terminal bronchioles and alveoli. And the blood supply to the alveoli, there's arteries and veins, and that actually are involved in gas exchange between the inhaled air, which has oxygen and carbon dioxide, and it gets into the bloodstream. So the lungs are the main organs involved in gas exchange through which carbon dioxide is exhaled out or breathed out and oxygen is taken in. So if there's a problem in any one of these, that would lead to impaired oxygenation and shortness of breath. So this is important as we are going to talk about scleroderma and the lungs. So alveolitis, which is inflammation of those air sacs that we talked about earlier, these air sacs. that will cause inflammation of the alveoli or air sacs is an important cause early in the course of the disease. Interstitial fibrosis can result from inflammation of those air sacs or alveoli, and the fibrosis or scarring of the space between the air sacs and the capillaries in the lungs, which is this area here. That's where you can see the fibrosis develop, and that's what is the hallmark of interstitial lung disease. In addition, we talked about aspiration, which is something that scleroderma patients are at risk of because of esophageal dysmotility, which is the cause of acid reflux disease and aspiration. And the most important for today's topic is pulmonary hypertension, which is disorder of the pulmonary or lung blood vessels, which are these blood vessels. So the disorder of those blood vessels, these blood vessels, that leads to pulmonary hypertension. And scleroderma is a condition where all of these different compartments can be affected. So the major clinical issue is defining the relative contribution of each process and choosing the appropriate therapy based on that. So interstitial lung disease in scleroderma. So this is a normal lung, and this is a CT scan, a thoracic CT scan, high resolution. The black is normal lung, and this is the heart in the center, and this is the aorta. These are the pulmonary arteries. So this is what normal lung should look like. In interstitial lung disease associated with scleroderma, which is not a topic for today's discussion, they look, all inflamed, and then, this white is actually suggestive of inflammation and fibrosis, which is very different from the one on the left. Scleroderma vasculopathy or blood vessel disease. That's the important, topic of today's discussion. So first of all, let's go over the structure of a blood vessel. So the blood vessel, which is an artery or a vein, here we are showing an artery or the arteriole, which is a smaller artery, has three layers. So the intima, which is the innermost layer here, which is normally a single layer of cells. And then comes the media, which is a layer of muscles, and these muscles can contract, causing the blood vessel to go into spasm. And the outermost layer is called adventitia, which is made of collagen, structurally normal collagen. So this is the structure of a normal blood vessel or artery. So in scleroderma, we have blood vessel disease. So it's called a vasculopathy or blood vessel disease, and it affects different vascular beds. When it affects the fingers, you get Raynaud phenomenon, ischemic ulcers, even gangrene. When it affects the pulmonary circulation, we get pulmonary hypertension. It can affect the kidneys and the microcirculation of the kidneys. That is the cause of scleroderma renal crisis. So here we are seeing the cross-section of a blood vessel from the finger, an arteriole from the finger. So that single layer has now become multiple layers. The lumen or the aperture inside has become narrow. And then the medial hyperplasia, which is something we are going to talk about, this striking fibrotic intimal proliferation, which is this layer. Then comes the medial hyperplasia, which is this is the media made of smooth muscle cells. Then the adventitia, which is also fibrotic and scarred up. So arterial lumen gets severely compromised because of progressive narrowing of these layers. And then that leads to a narrow aperture. And this, as I said, affects different vascular beds in systemic sclerosis. A little bit of the anatomy of the pulmonary circulation. So this is a heart. That's the left side of the heart. That's the right side. So the darker orange is left side, and the lighter orange is the right side of the heart. So the right side of the heart receives blood from the upper and the lower extremities through the superior vena cava. It's a big vein called a vena cava, and this is the inferior vena cava. So they go into the left side of the into the right side of the heart. That's called the right atrium, as you can see here. And I think these slides will be available to you later on for reference. And that's the right ventricle. So from the right atrium to the right ventricle, the blood flows through the tricuspid valve. And from the right ventricle, it goes into the pulmonary artery. So this is where all the problem happens in scleroderma pulmonary hypertension. The pulmonary artery divides into left and right. The left one goes to the left lung, the right one goes to the right lung. And after the oxygenation happens and carbon dioxide is blown out, the oxygenated blood comes back to the left side of the heart through the pulmonary vein. And that's how it comes to the left side here, the deeper orange. And that's the left atrium. From there, it goes into the left ventricle through this valve called the mitral valve. So the blood should be eventually pumped out of the left ventricle through the aorta. That's the big blood vessel that carries out blood out of the left side of the heart, and it goes to different parts of the body with oxygenated blood that is distributed. I think the questions can be at the end. If you have questions, we can try to answer those towards the end. So this is what happens in pulmonary hypertension. That's a normal blood vessel, normal pulmonary artery and arteriole, which are branches and sub-branches of these vessels coming out of the right of the main pulmonary artery here. In pulmonary hypertension, these vessels all get narrowed and progressively narrowed over time. And that leads to pressure buildup on the right side of the heart because the heart is trying to pump blood into these vessels and is unable to do so smoothly. As a result, the right side of the heart gets enlarged. The pressure builds up, and that's the pressure that we measure. And also the heart muscle gets thicker because it's having to work harder to push the blood through these narrower vessels. So an important distinction between pulmonary hypertension and pulmonary arterial hypertension. It's important to understand this. So there are types of pulmonary hypertension that you can encounter in systemic sclerosis or scleroderma. And this is the classification, the WHO classification or World Health Organization classification. There is group 1 pulmonary hypertension, which is pulmonary arterial hypertension. That's when the problem happens in the small blood vessels, but the lung tissue itself is not affected. And this is typically what you see in limited scleroderma or CREST syndrome. And that's the one that's called pulmonary arterial hypertension. Group 1 prime is called pulmonary veno-occlusive disease. It is now being recognized as an important complication in patients with scleroderma and pulmonary hypertension, and partly determines the relatively poorer outcome in these patients because the response to the medications that we now have available for pulmonary hypertension is mostly on these vessels, but less so on the pulmonary venous side. And we are going to have a nice picture in the next slide that will try to explain where the pathology happens in pulmonary veno-occlusive disease. Group 2 pulmonary hypertension is secondary to dysfunction of the left side of the heart. And again, the next slide will explain this. So when you have systolic or diastolic dysfunction, systolic dysfunction means the heart has difficulty pumping blood out, and the diastolic dysfunction means the heart has difficulty receiving blood from the left atrium. And as a result, because it cannot relax because of thickening of the muscle, either from scarring from scleroderma or from high blood pressure, that's diastolic dysfunction. When that happens, that's called group 2 pulmonary hypertension. Group 3 is the one that is associated with interstitial lung disease, where the blood vessels within the lungs are entrapped within the scar tissue that is caused by the inflammation in the alveoli and the septa, the interstitial lung disease that we discussed earlier. Group 4 is less common, but also does happen. So this is the blood clots that form within these small blood vessels within the lungs. It's called thromboembolic pulmonary hypertension. This is more of a complication of a clotting disorder that can sometimes coexist in scleroderma called antiphospholipid syndrome. So just for the sake of discussion, these are all the subtypes of pulmonary hypertension that can happen in patients with systemic sclerosis. So this diagram will explain things. Pulmonary arterial hypertension happens when the right atrium, this is the right ventricle, and the blood vessels get narrow on the pulmonary arterial side. So these are the blood vessels that get narrower and narrower, and these are the air sacs or alveoli and the blood vessels that are lining it. So when the pathology is mostly in this area, that's pulmonary arterial hypertension. When it affects the lung tissue scarring, causing entrapment of these blood vessels, causing pulmonary hypertension because of pressure buildup. That's called interstitial lung disease associated pulmonary hypertension. This is what pulmonary veno-occlusive disease is. That's the venous side. These are the pulmonary veins that's going to the left atrium. So the venous side, that's where the narrowing is happening. And that becomes a problem when we are giving medications to open up this side of the heart, but they are not that effective on this side of the heart. That causes some pressure buildup, and it can actually make the shortness of breath worse because the blood cannot flow, and there's increased flow through this side from medications, but it's still unable to flow through this side. That's pulmonary veno-occlusive disease. And then we talked about the left ventricular systolic or diastolic dysfunction, which is a result of thickening of the heart muscle or any problem with the heart valve here, which is not part of scleroderma, but that can also lead to pulmonary hypertension. So this is group 1 pulmonary hypertension that we talked about earlier. This is group 1 prime, which is pulmonary veno-occlusive disease. Then comes group 2 pulmonary hypertension from secondary, from involvement of the heart muscle on the left side of the heart. And this is group 3, which is associated with interstitial lung disease. So all of these things can happen in systemic sclerosis. So it's our job to figure out which is the main cause of pulmonary hypertension in the patient that we're dealing with. If it is this kind of pulmonary hypertension, which is group 1, that's the one that we typically see with limited scleroderma or CREST syndrome, where the lung tissue itself is not affected. So this is another way of depicting the same thing, the different subsets of pulmonary hypertension, pulmonary arterial hypertension, interstitial lung disease associated pulmonary hypertension, thromboembolic pulmonary hypertension. This is the left side of the heart being affected. And this is pulmonary veno-occlusive disease. So other than all the other causes of pulmonary hypertension, other than the one that affects the pulmonary arteries, all the other causes of pulmonary hypertension are called pulmonary hypertension. Only this one is called pulmonary arterial hypertension because the disease is confined to the pulmonary arteries. So this is the process by which pulmonary hypertension develops. So if you remember, we talked about the endothelium, which is the innermost layer. This is a magnified version of it, the endothelial layer. It's a single layer of cells. And these are the smooth muscles that can contract or relax based on chemicals that are liberated by these endothelial layer. And so there are 3 different pathways that seem to play an important role in modulating the contractility of these muscles, of the smooth muscle. And when these muscles contract, the blood vessel narrows and causes reduction in blood flow through the pulmonary arterioles. So the 3 pathways are the endothelin pathway, which is involved in vasoconstriction and proliferation. What does that mean? That means the muscles contract. Not only do they contract, the same mediators, the endothelin mediators, also induce fibrosis and proliferation or multiplication of these cells. So not only is it vasoconstrictive, it is also proliferative. And all the other 2 mediators, nitric oxide pathway and prostacyclin pathway, they are main mediators of vasodilation, which is relaxation of the muscle, as well as antifibrotic properties. So the way to address pulmonary hypertension with these new novel classes of drugs would be either to reduce the effect of endothelin or to potentiate the effect of nitric oxide and prostacyclin. So disorders of normal functions associated with pulmonary hypertension, we talked about it. Endothelial cell dysfunction plays a key role. Impaired production of vasodilators, which are chemicals in the body that open or dilate those blood vessels, such as nitric oxide and prostacyclin, as you saw in the previous diagram. And overexpression of vasoconstrictors, which are chemicals in the body that cause narrowing of blood vessels. Endothelin-1 and the other chemical is thromboxane A2. So if there's a imbalance between the vasoconstrictors and the vasodilators, the vasoconstrictors take the upper hand, causing more narrowing of the blood vessels. So this is a process that happens in patients with scleroderma, pulmonary hypertension. So there's more constriction and less relaxation of those blood vessels. And also the same mediators induce fibrosis and scarring, and that lead to progression of this disease. And then the vascular changes such as vasoconstriction, smooth muscle cell and endothelial cell proliferation, fibrosis and thrombosis can become a continuous perpetuating process. So this is a study that was published in 2010. It's the REVEAL registry. So out of all patients with pulmonary hypertension, only a small minority have inherited forms from mutations of certain genes. There's an idiopathic pulmonary arterial hypertension that is not associated with scleroderma. And then associated means pulmonary hypertension associated with various conditions. And of that, the big majority, almost 50% of that is connective tissue disease or collagen vascular disease associated pulmonary hypertension. And the scleroderma takes a big chunk of this fraction. So out of 100 patients, as you can see, 50% will have associated, and 50% of that will be connective tissue disease associated pulmonary hypertension. So nearly 25% of pulmonary hypertension is connective tissue disease related. And that could be scleroderma, lupus, mixed connective tissue disease, a whole host of other autoimmune rheumatic diseases in that category. It's common in scleroderma. The incidence of idiopathic pulmonary hypertension is 1 to 2 per million per year. This is pulmonary hypertension not associated with scleroderma. That's the disease just of the isolated disease of the pulmonary arterioles that can happen in young females more often than others. And then in pulmonary hypertension in scleroderma, it is about 10 to 15% of patients of limited scleroderma, 10 to 15% will get pulmonary hypertension. This is the one complication that can take sometimes many years to develop, 10, 15, 20 years after the onset of disease. The prevalence of other causes of pulmonary hypertension in scleroderma are 10 to 15%, which is all the remaining causes of pulmonary hypertension. And if you compare with lupus, the prevalence is only about 4%. So what are the signs and symptoms of pulmonary hypertension? At the onset, the patient may not even have symptoms because exertional shortness of breath will only come with exertion. If the patient is not exerting enough for various reasons, they may not even know they have early pulmonary hypertension. That's why the annual screening in high-risk population is mandatory, especially those with anti-centromere antibody and also patients with SCL70 and RNA polymerase III antibodies and remaining subsets. The first symptoms could be progressive shortness of breath on exertion, accustomed exertion, fatigue, some heart palpitations and coughing. As time goes on and the disease progresses, and if it's not recognized and not treated, symptoms and signs of right-sided heart failure, because now the heart is having to pump harder and harder to push the blood through the lungs, causing some fatigue and failure of the right side of the heart, chest pain, dizziness, syncope or passing out episodes, swelling of the lower extremities, and even free fluid in the abdomen. These are some of the late signs. We don't want our patients to get to that stage. We want to recognize it and address it before that happens. So how do you recognize pulmonary hypertension? As I said, these are the symptoms that the patient might experience, but the physician might listen to the heart, and the second heart sound in the pulmonary area, which is the adjective of the lung, can be loud. They might feel some increased heaving of the right ventricle, which is on the left side of the central bone called the sternum in the middle of the chest. And sometimes they hear a murmur of pulmonary regurgitation. And then there might be signs of right-sided heart failure, which could be, the neck veins are, distended. They may have some enlarged liver, some swelling of the lower extremities. When a pulmonary function test is done, there's a disproportionate drop in the carbon monoxide diffusion capacity, or DLCO, compared to the forced vital capacity, which is what you typically see in pulmonary vascular disease. And in interstitial lung disease, both the vital capacity and the DLCO goes down, whereas in patients with pulmonary arterial hypertension, the DLCO tends to go down more so than the vital capacity. And as a result, the ratio is often more than 1.6. that means that would be a suggestion that we should be screening for pulmonary arterial hypertension. The echocardiogram, this is the number that we look for. It's called the estimated right ventricular systolic pressure. It tends to be more than 35 to 40 millimeters mercury. Sometimes the right side of the heart that will be picked up on the echocardiogram will be dilated, suggesting that it's a failing right ventricle. And this is just to rule out chronic pulmonary embolism, or also known as thromboembolic pulmonary hypertension. A ventilation perfusion scan can sometimes be performed because some of our patients tend to have blood clots in the lungs causing the pulmonary hypertension. But eventually the gold standard and the only way to confirm the diagnosis is an invasive procedure called right heart catheterization. That's the only way diagnosis of pulmonary hypertension should be done. So this is a patient with limited scleroderma who do not have interstitial lung disease, but as you can see, the blood vessels are dilated because of pressure elevation and the narrowing of the vessels in the periphery of the lungs, but the central ones are dilated. So this is the profile of pulmonary hypertension in patients with limited scleroderma or CREST syndrome. And this is another patient who has group 3 pulmonary hypertension, where you can see a lot of scarring in the lungs, and pulmonary hypertension could be a consequence of that. So this is the natural history of skin disease in patients with scleroderma, just to say that in patients with diffuse scleroderma, the skin score, which is not a topic of today's discussion, tends to go up in the early part of the disease, then it stabilizes, and then it starts to regress over time. And this is somebody with limited scleroderma whose skin tightness is not as extensive and only affects the fingers, hands, forearms, and similarly feet and legs, but spares the trunk and in the upper arms and the thighs. That's why the skin score doesn't go that high. Pulmonary hypertension can happen in that subset even 10 to 20 years down the line, where all the other complications like interstitial lung disease, cardiac involvement, heart involvement, kidney disease, gastrointestinal issues tend to happen early in the course of the disease in the first 3 to 5 years after onset. So we tell our patients, if you have done okay for the first 3 to 5 years, chances are you're getting out of the woods, but you still need to be monitoring for pulmonary hypertension and severe gastrointestinal involvement in scleroderma, because that could be a late complication in a big subset of these patients. But as I said earlier, it's only in 10 to 15% of these patients. So this is a patient showing the central pulmonary arteriole almost occluded because of the scarring that happens in the different layers. And the same patient also has interstitial lung disease, as can be seen here by all the scar tissue surrounding those pulmonary arterioles. So this is a way to classify severity, and it is based on patient symptoms. So it's again a WHO functional class, which tends to correlate with severity of pulmonary hypertension. So patients without limitation of physical activity, ordinary physical activity does not cause undue shortness of breath, but they do have pulmonary hypertension based on the echo followed by the right heart cath. This is class 1 functional class. Then comes class 2, where ordinary physical activity causes undue shortness of breath or fatigue, chest pain, and these are the symptoms. And class 3 is less than ordinary physical activity. So these patients in class 2 are okay at rest, but when they're trying to do some physical activity that they're accustomed to normally, they are having difficulty with that because of shortness of breath. And here, their level of functioning has gone down. Just minimal physical activity is causing the symptoms. And here, the patients are unable to perform any physical activity at all without symptoms. So even small degree of physical activity make them short of breath. So this is just a gradation of severity of patient function, and that is what is called the WHO functional class. And it's important because this helps determine who needs to be treated and how aggressively patients need to be treated once pulmonary hypertension is diagnosed. So how do we diagnose pulmonary hypertension? So normally, as I have mentioned earlier, there are some other diagnostic tests that need to be conducted. Eventually, a right heart cath might be necessary. But every patient with scleroderma needs a baseline echocardiogram, a transthoracic echocardiogram, a baseline pulmonary function test that constitutes forced vital capacity and carbon monoxide diffusion capacity. And upfront, every patient should get a high-resolution CT scan without contrast of the chest. But once pulmonary hypertension is suspected, we need to get these other tests done to rule out other causes like pulmonary function test, chest X-ray, a ventilation perfusion scan to rule out thromboembolic disease. But eventually, the way to make the diagnosis is a right heart catheterization. And then that will dictate confirmation of diagnosis, severity, and will help us plan treatment. So patients newly diagnosed with scleroderma we should perform a baseline echo and pulmonary function. Patients with existing diagnosis should consider annual echo, at least annual echo and pulmonary function test. But the pulmonologists and rheumatologists these days are actually interested in getting these tests done even more frequently, like every 3 to 6 months, because changes can happen faster. And if you wait for a whole year, we may have had progression of disease without being recognized. So increased right ventricular systolic pressure is what you can pick up on the echocardiogram. Right atrial and ventricular hypertrophy, this is the heart, the 4 chambers. Normally the left ventricle, which is this, should be bigger than this. Here, as you can see, because of the high pressure buildup, the right ventricle is dilated compared to the left. And the septum, which should normally be the partition, which should bulge on the right side, is actually straight, and sometimes it goes in the opposite direction. That causes the left ventricle to be smaller in size, not enough blood pumping out of the heart, and that is the cause of syncope or passing out episodes in these patients. So the right atrium and the ventricle, as you can see, are dilated. Flattening of the septum and small LV dimension, which is the left ventricle gets smaller because this partition is bulging towards that side. And then the pulmonary artery can be picked up, which is not shown here, also can be dilated. This is a 6-minute walk test, which is controversial in patients with scleroderma because patients can be slowing down for other reasons like arthritis or bad circulation or deconditioning. But it's a quick bedside way to evaluate, how much the patient can walk, how long the patient can walk in 6 minutes. And that would be a parameter that can be followed over time if all those other confounders are taken into account. If it's the same patient who's been followed over time, and if their walking distance in a 6-minute period has gone down, that would indicate, progression of pulmonary hypertension or interstitial lung disease. But more so, this is a test that is routinely being done in patients with idiopathic pulmonary hypertension and in scleroderma-associated pulmonary hypertension. So a study was done where the long distance group, those who could cover more than 332 meters in 6 minutes, had a definitely better survival compared to those who had that cutoff of less than 332 meters. Patients walking less than 332 meters had a significantly lower survival rate than those walking further. So what is right heart catheterization? Basically, that's the gold standard way of making the diagnosis. So a catheter is introduced through either in the forearm, at the elbow region, or through the groin, and that catheter gets into the right atrium, and then it goes into the right ventricle, then it goes up into the pulmonary artery, and then it wedges in one of the terminal branches of the pulmonary artery. And these are the different waveforms that you can see that's picked up. There's a transducer, that yellow balloon that you can see, and the balloon is inflated, and the pressure here is directly recorded, and that's called the pulmonary artery wedge pressure. So increased mean pulmonary artery pressure, which is more than 20 millimeters mercury. That's the new definition of pulmonary arterial hypertension, along with the wedge pressure that I showed earlier of less than 15 millimeters. And wedge pressure is a measure of the pressure on the left side of the heart, like the left ventricle and the left atrium. So if that is elevated, that would be suggestive of group 2 pulmonary hypertension. That means pulmonary hypertension secondary to left heart disease, whereas in pulmonary arterial hypertension, the problem is in the pulmonary arterioles, and the left side should not be affected. So the wedge pressure should be normal or less than 15. Pulmonary vascular resistance is also now incorporated in the definition of pulmonary arterial hypertension. It's measured in this unit called Wood unit, and that can also be detected on the right heart cath. So these two cannot be measured with echo, but can only be measured with right heart cath, which is the gold standard of making the diagnosis. You have to fulfill all the three to call it pulmonary arterial hypertension. So this was a study that was done a few years ago, and this is an algorithm that was created. There's an app that actually incorporates all these different parameters. These are 6 non-echo variables, and it kind of, there is a complex formula to come up with a risk score of 300. So that includes vital capacity, DLCO, percentage, anti-centromere antibodies, which I said earlier is associated with limited scleroderma, presence of these red spots on the face and hands called telangiectasias, this number called NT-proBNP, which measures the stress on the heart muscle, the ventricles, both left and right axis deviation on the EKG, and serum uric acid. So all that is incorporated through a complex formula. If the score is more than 300, then there is a need to go to the step 2. If it's less than 300, no referral for echocardiogram is necessary. But if it is more than 300, then the patient do need an echo. And then these are the parameters that are measured on the echo, the right atrial area, and these are complex, numbers that our audience don't need to know too much about. The bottom line is, if the total risk score is more than 35, then these are patients who do need a right heart cath. So using this algorithm, which is called the DETECT algorithm, only 4% of patients with pulmonary hypertension were missed. By comparison, applying European Cardiology and Respiratory Society guidelines to the same patients, about almost 30% of diagnoses were missed. So this increases the yield of a positive right heart catheter-based diagnosis of pulmonary hypertension. And so once you diagnose it, you initiate treatment early. So this is a useful algorithm that can be used. So now we can talk. I have maybe another 10 minutes. Treatment of pulmonary arterial hypertension in scleroderma. So first of all, this is an important point to make. All scleroderma patients with pulmonary hypertension should be referred to a specialized pulmonary hypertension center for evaluation and management. This is a very complicated disease with a lot of different moving parts, and a specialized center probably would do most justice to making the diagnosis and offering the right treatment and following these patients over time. So treatment of pulmonary hypertension in scleroderma, it results, as we said earlier, pulmonary hypertension in scleroderma results from proliferation of endothelial cells, which is the innermost lining, and fibrosis of the small pulmonary arteries and their branches. So this is not as much of a spasm of the blood vessels as you see in idiopathic pulmonary hypertension. So there is no role for just isolated vasodilator therapy. It would be medications that will not only help open up the vessels, but also will help reduce the amount of scarring in those vessels. So the focus of treatment should be improving cardiac output, which is the amount of blood that is pumped out every time the heart is pumping blood out of the left side of the heart, inhibiting or reversing the proliferation and remodeling of the pulmonary vessels, the pulmonary arteries, which is the scarring process that goes on there. And then that has to be somehow slowed down or halted. And then obviously when the circulation is sluggish, there's a risk of clotting inside those pulmonary vessels. So if there can be any way of trying to slow down that process as well, which further narrows the opening or the lumen of the blood vessels. So the indications for medical treatment of pulmonary hypertension. WHO functional class 1, which we talked about earlier, those who are asymptomatic, all we need to do is observe those patients and follow them very closely and on a regular basis. They should be clinically monitored for disease progression to a functional level that may warrant therapy at a later date. So any coexisting conditions that worsen pulmonary hypertension should also be recognized and treated. And that could be conditions like obstructive sleep apnea, left heart disease, interstitial lung disease, etc. On the other hand, functional class 2, 3, or 4 need medical treatment. Patients who with WHO functional class 2, 3, or 4 should be referred to a specialized center to be evaluated for specific pharmacologic therapy. The goals of treatment would be achieve at least a WHO functional class 2, if not even better than that. Normalize mean pulmonary artery pressure, which was picked up on the right heart cath. Improve 6-minute walk distance to more than 380 meters. Minimize adverse events of these medications, which are complex and needs specialized care. Overall goal is to improve survival and improve quality of life. So as we talked about the 3 different pathways, earlier we talked about the endothelin pathway, nitric oxide pathway, and the prostacyclin pathway. These are mediators that not only help open up the vessels, but also help reduce the fibrosis. So we can either use potentiators of the prostacyclin pathway, which are called prostacyclins, and the drugs are epoprostenol, treprostinil. This is complicated. I have a slide in the next, the next slide actually gives all the different drugs that are available for treatment. So these are the potentiators of the prostacyclin pathway. Then these are potentiators of the nitric oxide pathways, sildenafil and tadalafil. And then comes inhibitors, or those that block the constrictors. Bosentan, ambrisentan, macitentan, they are called endothelin-1 receptor antagonists. To this, we have new classes of drugs added. This is called riociguat, which is a selective guanylate cyclase stimulator that actually also potentiates the effect of nitric oxide. And then the newest kid in the block is a prostacyclin receptor agonist, which stimulates or activates prostacyclin, but itself is not a prostacyclin, but it works on the same receptors. It's called selexipag. So these are all the drugs, and you can take your time to review this. Bosentan, ambrisentan, macitentan, the endothelin receptor antagonist. Then the prostanoids, which is epoprostenol or Flolan, which is used for more severe pulmonary hypertension. Treprostinil in the same class, but it has a subcutaneous or intravenous form, an inhaled form, and an oral form. And then iloprost or Ventavis, which is inhaled. And then phosphodiesterase inhibitors, sildenafil and tadalafil. So within parentheses, I have their brand names. Soluble guanylate cyclase stimulator, which is riociguat, and then prostacyclin receptor antagonist, selexipag. So sequential therapy versus combination therapy. So you can consider starting with a single agent and then add another agent. Some more recently done studies indicate both for idiopathic pulmonary hypertension, all causes of pulmonary hypertension, combination therapy upfront has a better outcome compared to sequentially adding other drugs. And even in the subset of patients with scleroderma pulmonary hypertension, combination therapy of endothelin receptor antagonist and phosphodiesterase inhibitor tended to have better outcome, as is shown here. So this is the arm that shows event-free survival over 168 weeks. Pooled monotherapy, that means those who got a combination of tadalafil and ambrisentan from the beginning tended to have better outcome compared to those who got either ambrisentan or tadalafil separately. And kind of common sense, but the study kind of confirms that as well. So this is the treatment algorithm for scleroderma pulmonary hypertension, WHO functional class, which is what we talked earlier. Treat contributing factors and observe till they progress to WHO functional class 2, and there you use the combination therapy, as we said, and other options are also there. And for class 3, which is more severe, you can use that combination, but there's some alternatives, single agent therapy. And for people who are progressing from class 3 to class 4, you can initiate the intravenous epoprostenol and some other forms of prostanoids. If there is in class 4, the preferred initiation should be with epoprostenol or a treprostinil intravenously. This is through a continuous pump. If there is no improvement or deterioration, you can use a combination of these with some of the oral agents that we talked earlier. And then eventually, if there's no response or progressive worsening, patients can be considered on a case-by-case basis for lung transplant or atrial septostomy, which is a procedure, which is a palliative procedure, creating a hole in the atrial septum, interatrial septum, to at least reduce the pressure on the right side of the heart. Some of the blood flows through that hole to the left side, but at least it improves survival, as studies have shown. These are all the drugs, all the details, and you can take your time to review this. Route of administration, dose, half-life are all mentioned here. Supplementary therapy with oxygen, digoxin sometimes is used, and we will talk who are the ones who would require oxygen. Loop diuretics for people who have right-sided heart failure can go on one of these medications to reduce the fluid retention. Spironolactone has a special role, which is an aldosterone antagonist. We can use warfarin and calcium channel blockers in idiopathic pulmonary hypertension, but their role is not prominent, and they can actually worsen the risk of bleeding from lesions in the gastrointestinal tract. So it's not a very popular therapy. Blood thinners are not popular in patients with pulmonary hypertension related to scleroderma. And calcium channel blockers only work in a small subset of patients with idiopathic pulmonary hypertension, but has not been found to be effective in dealing with pulmonary hypertension and scleroderma, and so are not used. And long-term oxygen therapy, if the pulse ox shows oxygen level of less than 90%, and I think the audience is aware of pulse ox since onset of COVID. You can measure the blood oxygen level either with a blood gas test, but at least at home, if your oxygen level drops less than 90, then you are going to qualify for oxygen. If the EKG shows evidence of right atrial enlargement and strain on the right side of the heart, high red blood cell count or hematocrit due to chronically low blood oxygen level, your body tends to raise the hemoglobin level so that you can improve the oxygen carrying capacity. That's telling us there is a distress signal. That would be an indication for oxygen therapy. Clinical evidence of right-sided heart failure. Oxygen should also be prescribed during sleep and exercise, and the dose should be adjusted appropriately. And if those who only drop their oxygen level during exercise, oxygen is prescribed for use during exercise only. Lung or heart transplant, just a few words. The prognosis has been shown to be not any worse than those with pulmonary hypertension from other causes. So it is a viable option in selected patients, but obviously there's a concern about destruction of the transplanted lung from bad acid reflux. So some surgical measures may have to be adopted, and post-transplant patients often go on this medicine called tacrolimus to prevent rejection. So that is something to also discuss, and selected patients might be appropriate for a lung transplant. The prognosis, as you can see, is worse when patients have pulmonary hypertension compared to those who have interstitial lung disease with scleroderma, or those who do not have lung disease of any kind. But newer data indicate that maybe the pulmonary hypertension in scleroderma survival maybe is improving with the newer classes of drugs. This is a more recent study demonstrating the same. Overall survival was 90%, 78%, and 56% after lung transplant at the end of 1, 2, and 3 years from pulmonary hypertension diagnosis. So in summary, pulmonary hypertension is a complication of scleroderma-related blood vessel injury. As many as 10 to 15% patients with scleroderma develop pulmonary hypertension. It progresses rapidly in scleroderma, therefore early detection and treatment are critical, and multiple therapies are available that can favorably alter the natural course of the disease. So action items for the patient with scleroderma: discuss your breathing with your physician, with your primary care provider, and your regular rheumatologist. Understand the rationale for testing and the complexities of pulmonary hypertension. So make sure you get a baseline echocardiogram and get one at least annually. And then earlier diagnosis leads to earlier treatment, which is kind of common sense, and it probably alters the natural history of disease. All patients should be referred to a specialized pulmonary hypertension center for evaluation and management. Expect the best, but be prepared for the worst. But at least, the newer therapies have really altered the natural history in a favorable manner. Some unanswered questions: does treatment of mild pulmonary hypertension alter long-term outcome? How do patients with pulmonary hypertension and interstitial lung disease respond to therapy? If patient has both, which one is mostly responsible for the symptoms that the patient has? Which one should be addressed? The recommendation would be assess the severity of both interstitial lung disease and pulmonary hypertension and address them at the same time. Is there a survival benefit in scleroderma patients compared to idiopathic pulmonary hypertension? And do endothelin receptor antagonists and phosphodiesterase inhibitors alter the course of the pulmonary hypertension in scleroderma? And I think there is overwhelming evidence and growing body of evidence that probably it does. So early recognition, early treatment is important. So thank you very much. If you have questions, I can answer. If it goes a few minutes beyond, I'm fine to answer them.
Great.
Thank you again.
Thank you, Dr. Chatterjee. That was amazing. A lot of information. We have a couple of questions.
Okay.
All right. Is a right heart catheterization only needed once?
It is needed once we have suspected the selected patients who have a high index of suspicion of pulmonary hypertension. Based on symptoms, based on their echocardiogram, they get a right heart cath. And the right heart cath has to be done in a specialized center. And you initiate therapy based on that information. And if the patient is not adequately responding, if the patient is worsening, a repeat right heart cath may be necessary down the line, but at least an annual echocardiogram is necessary. And if pulmonary hypertension has been established, patients would require echo maybe every 3 to 4 months. And if the numbers on the echo are showing a significant worsening, to get a better understanding of the pulmonary hypertension, right heart cath may have to be repeated. But it's not a recommendation to do an annual right heart cath. It's an invasive procedure with some risks associated with it. So it would be only indicated if the patient is not adequately responding to the current regimen.
Thank you. We have another question. What is your experience with limited systemic sclerosis patients on mast cell stabilizer drugs, specifically the effect on pulmonary arterial hypertension?
They can be used. I don't think there is overwhelming data in the pulmonary hypertension community of experts. I do not bank on those agents. The mainstay of therapy are the 3 classes of drugs that we talked about: the phosphodiesterase inhibitors, the endothelin receptor antagonists, and the prostanoids. Other agents can be used in refractory cases, but the mainstay should be these classes of drugs, either in isolation or in combination.
Thank you. We have another question. Can you explain diastolic dysfunction and how do we as patients quarterback both rheumatology and cardiology?
So diastolic dysfunction is not at all uncommon in patients with scleroderma. The heart muscle, like fibrosis in other organs, the heart muscle can also be affected by this fibrotic process, making the heart muscle stiffer. So the heart should be able to relax, to accept blood from the left atrium and the right atrium. And then the more it accepts blood, the more it can pump out the blood. So when people have stiff ventricles, that leads to inability to receive as much blood. That is what diastolic dysfunction is in simple terms. And systolic dysfunction is obviously when the heart is not able to pump the blood out because of failing ventricles. I hope I tried to explain it. I hope
yes. Thank you. One more question. Is it possible to have ILD and PAH together?
For sure. That's why I think I may have discussed this. You recognize both, and treatment of one does not treat the other. So there are patients with, for example, group 3 pulmonary hypertension. These are patients who have interstitial lung disease and pulmonary hypertension secondary to entrapment of those blood vessels within the scar tissue of the lungs. That's group 3. And that's the kind where you get both interstitial lung disease and pulmonary hypertension. And the severity of one doesn't necessarily dictate the severity of the other. So some patients may have severe interstitial lung disease with no pulmonary hypertension or mild pulmonary hypertension, and some can get the other kind, which is severe pulmonary hypertension with mild non-progressive interstitial lung disease. And that would suggest that these two processes can go on independent of each other, side by side. So yes, patients can get both of these, and that would be unfortunate, but it does happen, and both need to be treated independent of each other.
Thank you. One last question. They say, many thanks for the fantastic talk. Could you explain on what is known about long-term treatments for nitric oxide and prostaglandin?
So nitric oxide is basically the mediator that causes dilation of the blood vessels and anti-fibrosis. That means it reduces the scarring of the pulmonary vasculature. So the drugs that we talked about earlier, the phosphodiesterase inhibitors and riociguat, they work on this pathway that help to opening up of the blood vessels and reducing the scarring of the blood vessels. That's how they work. So they are not only vasodilators, but they're also anti-proliferation, anti-fibrosis. And that's a big part of what determines bad outcome in idiopathic and scleroderma associated pulmonary hypertension. So not only are these vessels narrowing from the contraction of the smooth muscle lining of the vessels, but also there's scarring and progressive narrowing, which is not entirely reversible unless medications are initiated early to reduce the scarring process, the fibrotic process, and the proliferative process.
Thank you. Any parting comments as we wrap up today's session?
Thank you for attending, and I'm happy to pass the message on. I'm not sure how many physicians are logged in. The message is, it is important for scleroderma patients to be referred to specialized centers with or without pulmonary hypertension, because all these nuances and the individual care that these patients need can vary from patient to patient. And I think there are so many moving parts, as I said earlier. It's important to refer these patients. The primary care provider may not have enough patients in their practice, enough experience managing them. So it's preferable and to the best interest of the patient to refer them to a specialized center where they see many more patients with this condition. The other advantage is we share our patients with pulmonologists, gastroenterologists, cardiologists, whoever is necessary in a multidisciplinary model to manage our patients. So whenever we need help from our colleagues in other specialties, it is readily available, and they all are invested in taking care of patients with this very complex disease. And I think the outcome is best for the patient if that can be accomplished. And patients should also be their own health advocates and make sure that their primary care provider is able to refer them to an appropriate center nearby where they can be better taken care of.
Thank you so much. In closing, I would like to thank Dr. Chatterjee for sharing your time and expertise with us today. And also thank you to our attendees that logged in or dialed in today. And a special thanks to Janssen Pharmaceuticals for sponsoring this event. This will conclude today's webinar. Be well and have a great day. Thank you again.
Thank you very much, and have a great day, everybody.